So Guillain-Barré, an autoimmune disorder that also causes damage to the myelin, but in this case, the inflammation causes the hallmark symptom of Guillain-Barré, which is paralysis that begins in the feet and works its way up the legs until it gets to the torso and then eventually paralyzes the respiratory muscles. So it's an ascending paralysis. That's the hallmark sign for this. And usually, when you're taking a history of a patient with the diagnosis of Guillain-Barré, they're going to report that they had either a respiratory or a GI bug, either viral or bacteria, within about 1 to 3 weeks prior to the onset of these symptoms. So those are very common triggers for this autoimmune response for the Guillain-Barré disease. Yes?
What was, before you said GI bug, what was...
An upper respiratory. So any kind of a viral, you know, they've had a bad cold, they had a GI bug, other things, and oftentimes that is part of their history within the prior 2 to 3 weeks of the onset of these symptoms. Yes? They sound similar, but I'm going to tell you what the difference is. So Guillain-Barré, it does affect your nerves. It affects sensory and motor nerves. It's an ascending paralysis. And then what happens is the patient gets to the point where they're ventilator dependent. And then they plateau, where they're on the ventilator for a while. And that plateau can last for maybe some days or weeks. And then when the process starts to resolve, the paralysis will resolve back down in the direction that it came from. So it's an ascending paralysis, and then the symptoms resolve in a descending manner. Now, depending on how long that patient has been in that plateau state, how severe this autoimmune reaction is, they may have some neurological deficits even after all the main symptoms go away. If they've had a case of Guillain-Barré, they're more likely to get another one. They're going to be more susceptible to having that reaction again. Yes?
And other than the minor to severe effects afterwards, it's just something that knocks them out for a while and then...
Right, and eventually their body stops, you know, that autoimmune response resolves and dissipates, and then the paralysis recedes. And then, let me see where we go here. So diagnostically, what we're going to be doing is we're going to be taking that history and physical, and the vast majority of the time, people are going to report that upper GI, the GI or upper respiratory bug. They're going to have elevated protein in their CSF, so they'll probably have a lumbar puncture done. And there's nothing that can really cure it. What we can do is treat the symptoms and try to reduce the inflammation. So Solumedrol, corticosteroids, very common. I've already said that as a treatment for a lot of neurological conditions that we've already talked about. So Solumedrol. The preferred treatment is IV immunoglobulin, IVIG. And what that does is it has antibodies that counteract and override those autoantibodies that the patient has developed that is attacking the myelin in their body. So it can have some side effects like the interferons have with fever and chills, and the patient can be very uncomfortable. Plasmapheresis, which we talked about with myasthenia gravis. What was that?
Take the blood out, you take away the stuff and you put the plasma.
Right, so you're removing the blood, you're doing like a dialysis, only you're taking out those antibodies that the body has produced to attack itself, the autoimmune antibodies, and replace it with some plasma so they don't lose blood volume. And again, some of the complications patients can experience with plasmapheresis is hypovolemia and dysrhythmias. Okay, I'm going to pause this, our recording. So any questions about GBS, Guillain-Barré? So now we're going to move on to Parkinson's. So the problem with Parkinson's is that we have a lack of dopamine, a decrease in dopamine levels. And dopamine is a neurotransmitter that helps us with our fine motor movements. And when the patient has problems with their dopamine levels, they have very specific set of symptoms that with Parkinson's, if you remember the acronym TRAP, those are your 4 typical symptoms of a patient with Parkinson's. Tremors, rigidity, akinesia or bradykinesia, which means what? Right, lack of movement or slow movement. And P for postural hypotension and postural instability. So patients with Parkinson's have very fine tremors because of that lack of dopamine. They have rigidity, so their face will be very mask-like, their muscles will be stiff. They will have akinesia or bradykinesia. If you've ever worked with a Parkinson's patient, it takes them forever to get up from a couch and walk across the room because they freeze and their muscles freeze. And they are at a very high risk for orthostatic hypotension and falls. What other things have you seen with patients that have Parkinson's? The mask-like face. What's that? Pill rolling, yeah, that's a very common, almost an early sign of Parkinson's, where patients will kind of do that with their fingers, like they're rolling a pill between them. Drooling, they have a lot of problems with managing their secretions, swallowing.
Hunched over, shuffling gait.
Yep, a hunched over shuffling gait. So they are a fall waiting to happen for a lot of reasons. They can have some dementia in more advanced stages of Parkinson's, but not really hugely significant like we're going to see in, for instance, Huntington's disease. The pharmacology is basically medications that are going to help to improve the levels of dopamine. And the most common medication that you're going to see is Sinemet, which is a combination of levodopa, which is a precursor to dopamine, so it helps to convert the dopamine levels, and carbidopa, which enhances the effects of the levodopa. So it's a combination drug, Sinemet, that you'll see very frequently with patients with Parkinson's. Patients can have what is called deep brain stimulation, where they have an electrode implanted in the brain, and the part of the brain that they focus on is what is called the substantia nigra, which is where dopamine is produced and regulated. So this electrode will stimulate the substantia nigra to produce more dopamine and improve their symptoms. Patients that take the medications for Parkinson's oftentimes have to go on a drug holiday. What would be the purpose of a drug holiday? What does that mean? Right, we stop the drugs to see what their baseline is, and oftentimes we have to stop the drugs because they're not getting a good effect from the drugs that they've been on. So if we remove the medication for a week and a half, and then start it up again, we can usually get back with a reasonable dose. We don't want to have to keep increasing the medications to have an improvement of symptoms. And our supportive care is going to be based on our issues of safety, fall prevention, aspiration precautions. So they may need a speech and language pathologist to help them with swallowing issues, and even with some of the cognitive issues that they might have. So that is it on Parkinson's. Any questions on Parkinson's? Okay, the next is something that was not in your book, and I don't know why it was not in your book, because it's something that you're going to run into occasionally. I had at least 2 or 3 patients in home care that we treated that had Huntington's disease. So did anybody get a chance to look it up or find any information on it? It's not a very good disease. It is a neurodegenerative disorder, and the thing that's unique about Huntington's, it is an autosomal dominant mutation. So it will be in a family, and in order for the child to get Huntington's, one of their parents has to have the mutated gene, and they will get the disease at some point if they get the mutated gene. The problem is that it doesn't show up oftentimes until later on in life, age 35 to 50, is the mean onset, which means that most people who don't know that they have that mutation in their family line have already had kids. And every child that they have has a 50% chance of getting that mutated gene from the parent who has that. It can be really a horrible situation. Many times families did not know that the gene was in there, that the mutation, the disease was in their family line, because people didn't live as long as they do today. So many people died before the disease had a chance to manifest itself. There was, 2 world wars, Vietnam, car accidents, cancers, a lot of things that people can die of before they get old enough to develop the signs and symptoms of Huntington's. So you'll see a lot of tragic situations in families where children were born into families that did not even know that they had this horrible genetic mutation. What happens with this is that with the mutation causes an imbalance in different types of neurotransmitters, those that inhibit nerve impulses and those that increase or excite nerve impulses. So you have these very jerky, purposeless movements for patients that have Huntington's. They're called choreiform movements. It used to be called Huntington's chorea, and then they politically corrected it to Huntington's disease. So the diagnosis is going to be based on either a knowledge that you have that genetic mutation in your family, and then that along with the choreiform movements and dementia. Patients with this particular condition develop very severe psychiatric issues and dementia, along with their physical deterioration. And the disease and condition can last from onset to death 15 to 20 years. There is no cure, there is no treatment. The only treatment that we do for Huntington's is symptomatic. If the patient's depressed, we give them antidepressants. If they have psychiatric issues, we can try antipsychotics. But that's pretty much all that we can do for them. Now we're going to talk about ALS. And ALS, otherwise known as Lou Gehrig's disease, and something I heard recently, they think that maybe Lou Gehrig did not in fact have Lou Gehrig's disease, that he had some other type of neurological, which I think is kind of ironic. But anyway, this is another progressive degenerative nervous system disease that involves only the motor neurons, and it has to involve both upper and lower motor neurons in order to be considered amyotrophic lateral sclerosis. So that's where this differs from multiple sclerosis, because multiple sclerosis is sensory and motor nerves. ALS is only the motor nerves. The other difference between a lot of the things that we've talked about is that there's no cognitive issues. There's no dementia related to the ALS. Now, if there's other issues in that patient, that might cause dementia, but it's not because of the ALS. So what happens with this patient is their muscles become weaker and weaker, and eventually they end up on a respirator. Eventually they really have no significant movement whatsoever, so they have a nice alert, oriented brain trapped inside a body that won't move. We don't locked in. That's similar to there's other conditions that they could use that they use that term as well, and with some traumatic brain injuries there's the locked in syndrome. But yeah, this is the type of thing that an ALS patient experiences. Their body's deteriorating and they're alert and oriented and totally aware of what's going on, and the fact that they're not able to do things. They don't know really what causes it. Sometimes viral infections will trigger it, and it's like an inflammatory response. They think maybe glutamate, which is a neurotransmitter, if there's too much of that can cause the onset of it, but they really don't know. There's a lot of research, but not a whole lot of information as to what causes it. So we basically monitor that patient. There's no really medical treatment for them. We support their respiratory status. Feeding tubes, whatever is needed to, prolong life. And many patients, I think in fact that the very first assisted suicide with Dr. Kevorkian was a woman who had either ALS or Alzheimer's. I can't remember which it was, but she had made the choice before she deteriorated to a certain point that you know, she wanted to she wanted to self-euthanize. Yes. It can affect their ambulation. It can affect you know, arm strength. I knew a patient who the only problem that she had initially was she couldn't swallow. She was up walking around. She had to have a peg tube just because she couldn't swallow, because the ALS had paralyzed her throat muscles. Could you close that door, please? Oftentimes from diagnosis to respiratory failure and death, it's a few years. But there are some patients that will last much longer. So you may see some patients that have been diagnosed with ALS that have had it for many, many years. Stephen Hawking, the physicist, supposedly has ALS and has been around for quite a while. A patient that I had in home care was diagnosed in his 20s, and the last I heard when he was a patient in the ICU at Johnson was pneumonia, and he was in his 50s. So, you know, he basically, his kids knew nothing other than dad having this disease and deteriorating over the course of probably about 10 years it took him to become ventilator dependent. And then he's probably been on the vent probably for maybe another 20 years and still alive. Yes. Oftentimes it happens like in between the ages of 20 and 40. So, you know, childbearing, you know, you've started having a family, you started out in your career, and then boom, you get this disease. So any other questions about ALS? So the next thing we're going to talk about is back injuries, like my little prairie dog there. And back pain is something that as nurses you are going to be making sure that you try to prevent in yourself, and taking care of patients who are having procedures based on back issues. Because of a lot of the types of jobs, a lot of people being on computers, a lot of people being on computers just for fun, a lot of people are getting cervical disc issues, lumbar disc issues if you don't use good body mechanics when you're moving your patients. So who can tell me what the nucleus pulposus is? Right, it's a soft, spongy stuff on the inside of the disc. So you have like a cartilage called the annulus that surrounds that nucleus pulposus. That's the tough part of that intervertebral disc. Here's a picture of it here. And the nucleus pulposus, who's nice and soft and helps to, you know, help with the impact and the shock absorption in your disc. And what will happen, either because of accidents or repetitive stress, that annulus will crack and open up, and the nucleus pulposus will herniate out, causing impingement of the nerves. Now, back in the day, before diagnostic-related groups, DRGs, and insurance companies kicking patients out when they were barely out of the OR, we would actually have patients come in through the emergency room with a diagnosis of HNP, herniated nucleus pulposus. They were admitted to the medical surgical floor with orders for bed rest, Percocet, and Robaxin. Yeah. And traction or Williams position, which is the head of the bed up and the knees gatched, so it would reduce the stress. But just think of how nice that must have been. I mean, you know, unless you had really excruciating back pain. But there were a lot of people that came in that I don't think their back pain was all that excruciating. Maybe their family life was excruciating. This was a nice 3-day vacation, you know, from the kids, from the job, whatever. And we just medicated them pretty much around the clock with the Percocet and the Robaxin, and they were on bed rest. Now you go into the emergency room and, you know, they hand you the prescription and tell you to go home and find someplace comfortable to lie down, which for many people is the floor, because most people don't have hospital beds at home that they can adjust and get comfortable for them. So things have definitely changed, probably for the better. I mean, that was a little ridiculous, and that's why insurance costs got pretty high there for a while, because people stayed in the hospital for way too long. So that was patients that we dealt with. So conservative treatment is rest, ice, If it's an acute injury, so for the first 24 hours, ice, and then heat. Why ice first and then heat? Right, the ice reduces the inflammation, and once the inflammation goes down, what does the heat do? It improves circulation and it relaxes your muscles. So those patients who have back spasms, muscle spasms because of these herniated discs, the patients will have what's called sciatica, where the sciatic nerve is pinched if they have a lumbar disc problem, and the pain shoots down down the buttocks and down the back of the leg, can be very, very painful. Cervical pain that patients can have with herniated discs can be pain and burning sensations on their arms, numbness and tingling. So conservative treatment is, where they all want to start. And then the next thing they're going to do is to do steroid injections. So I'm sure anybody with back pain now that hears the word steroid injections is getting pretty nervous, because that's what all those people who died of fungal meningitis died from, solumedrol injections for back pain. Yes.
What was the
Head of the bed up, knees gatched, bent. I can't believe you knew 220. You haven't heard the term gatched. That's an old that's an old nursing school. As the knees were gatched. Back in the days before electric adjustments of the. God, I'm really dating myself here. It's awful. So anyway, Williams position, because it takes, if anybody's had any kind of low back pain, if you sit in bed you're lying in bed and your legs are straight, your knees are out straight, it just pulls on your lower back and really increases the pain. So with the knees bent really helps to relieve the pressure. If the conservative treatments don't work, then we have surgical treatments. And they have a lot of minimally invasive surgical treatments for disc repairs. Endoscopic repairs, laser surgeries, tiny little percutaneous incisions. If the patient has a severely herniated disc where they need to either remove the disc or remove part of the vertebrae or do a fusion, then they'll do an open surgical procedure. And depending on where the herniation is, if it's a cervical disc and it's an anterior problem, they will approach through the neck, front of the neck. If it's a posterior, they'll go through the back. If you have an anterior lumbar disc issue, they will approach through the abdomen rather than going through the back. So they want to get to it the most direct way and either remove the disc, shave off the areas that are causing impingement on the nerves. If they have to remove the disc totally, then they need to do a fusion. And they will use bone chips to fuse that, and they will put bone chips in the surgical area, and then they will grow to fuse the two vertebrae together. Patients can have those bone chips taken from their iliac crest, and most patients complain of more pain from that than they do from their actual surgical incision. They can get the bone chips from cadaver bones, and they will also recently have started using electrical stimulation, like a TENS unit, only to use it to stimulate the bone growth. So a lot of patients with disc surgery are in and out in like a one-day surgical procedure. The more invasive open surgical procedures, it could be 2 or 3 days of post-op recovery. Now, patients will have not only muscle issues, muscle pain, muscle spasms with disc issues, but they can also have nerve compression that can cause some very unpleasant symptoms like urinary retention, incontinence, bowel and bladder issues. So if they have nerve compression, some of these symptoms are going to show up with your patient. So it's not just the muscle pain, not just the pain in the lower back or in the neck. They can have some other issues that are related to nerve compression. So if your patient's had any one of these surgeries, particularly the open surgeries, what would be your post-op assessment for both types of surgeries, whether surgical or lumbar? CMS, so neurovascular status, neuro checks. If they have a dressing, what are you going to check the dressing for? CSF leak, so the halo sign. If they have a cervical disc, what complication might you see with that, or do you have to be alert for? Respiratory problems, because if they're doing any kind of surgery in the neck area and there's edema as a result of the surgery, that patient's airway could get compromised. So you're going to be assessing neurovascular status, all that other stuff with the lumbar, and then with your cervical, you're also going to be assessing your respiratory status and looking for things like hoarseness, stridor, other indications that their airway is closing off. So any questions about discs, surgeries? And the last condition we're going to talk about is stroke. So what's a stroke?
Lack of oxygen to the brain.
Lack of oxygen to the brain. And it can be either ischemic or embolic or thrombotic. You can hear it referred to as those three. And that's because of what? Clots. So the artery, the circulation is occluded, and so nothing is getting past that clot to get to that area of the brain. Or you could have a hemorrhagic stroke, where a blood vessel ruptures and the patient bleeds out into the cranium and into the other brain tissue, but it's not getting circulation to the brain tissue. So for your ischemic strokes, a lot of the risk factors for patients for ischemic strokes are the same risk factors that you learned with Virchow's triad. Anything that predisposes a person to a DVT is going to make them at risk for stroke. Because if that blood clot doesn't break off and go to the lungs to cause a pulmonary embolus or to the heart to cause an MI, it's going to go to the brain and cause a stroke. So all those things that predispose a patient for developing DVT is also going to put them at risk for stroke. Other things are going to be things like untreated atrial dysrhythmias or valve problems. Why would that put a patient at risk for stroke? Right, because the stasis of the blood in the atria is going to form clots, and then that patient is going to shoot clots off, usually to their brain. Probably atrial fib, untreated atrial dysrhythmias is one of the most common causes of thrombotic or ischemic strokes. If you have a family history of strokes, you are at a higher risk. If you are male, if you are older, if you are African American, all of those three make you at a higher risk for stroke. So the older African American men have a triple whammy risk factor. So the case study we're going to talk about is Mrs. G. And she is a 59-year-old widow who works full-time in an insurance company. Her hobbies are golf, travel, and sewing. She's a non-smoker and a social drinker. So what are her risk factors for stroke? Right, so she has a sedentary job. What else?
Travel.
Traveling, so sitting in airplanes or cars. What else?
Her age.
Her age. Although after I pass 60, 59 seems very young. What other risk factor does she have? She has a sedentary job. What else? Sedentary hobby. I mean, the golf is nice, but the sewing, sitting at a desk all day and then coming home and sitting in front of a sewing machine. The non-smoker, social drinker, those are, good things that she's, not going to have those as a risk factor. So she had a possible TIA 6 months ago. What's a TIA? Transient ischemic attack. So what does that mean?
Signs and symptoms, but no permanent damage.
Right, so they're going to have signs and symptoms of stroke. Transient means it comes, but then it goes. Ischemic, lack of blood supply to the tissue. So patients with a TIA will present with very common recognizable symptoms of stroke. So what are some of the things that they might present with a TIA? One-sided weakness, facial droop, speech impairment, numbness and tingling. So all the things that you would associate with a stroke, those patients come in with the TIA. And so that's why you're going to work them up as if they're having a stroke to rule out a CVA versus a TIA. And then if that patient has had a TIA, you want to teach them the acronym FAST for the signs and symptoms of impending stroke. So F stands for facial droop. A stands for arm weakness. S, speech. And T, time. Time is of the essence. So when we talked about MIs and we said time equals muscle, in here, time with a stroke, time equals brain tissue, neurological, intact. So today, Mrs. G is at the emergency department. She has slurred speech, right upper and lower extremity flaccidity. And her family reports that she has a history of rheumatic heart disease and a heart murmur. So what type of stroke did she have? She had thrombotic, ischemic, embolic stroke. Because of that heart murmur, she's probably developing clots, and those are going to the brain, and probably was what caused the TIA 6 months ago. So here's some of the signs, the symptoms that you'll be assessing Mrs. G for. What is dysarthria? Difficulty speaking, but not the slurred speech. The dysarthria is problems with the muscle movement of speech, the mouth, muscles in the mouth. It can be slurred speech. Part of that can also be because of the aphasia with an S. So dysarthria will be problem speaking, slurred speech, some swallowing issues perhaps. Dysphagia or aphasia with an S can be in two different categories. It can be expressive, which is what? Right, patient has trouble communicating. They have slurred speech, they have trouble with word retrieval. They have, or they're not able to speak at all. Everything is just garbled and just random noises. What is receptive aphasia? Understanding. And many times patients will have both, but sometimes patient will only have receptive aphasia. So you're talking to that patient and they're communicating with you and they're talking back and they don't sound, they're not slurred, they're not having trouble with word retrieval, and you think they're understanding everything that you're telling them. Except after a while you realize they're not understanding everything that you're telling them, but they're going to smile and nod and agree with you and start talking as if they do. So many patients, when you're assessing their baseline abilities after a stroke, carry on a little bit of a conversation and see what you get back from that patient where you might suspect receptive aphasia. What is apraxia? Yeah, they can't perform a previously learned action. So it's very hard for that patient, you tell them to go and to do something like, go write something on the board or whatever, or go throw a piece of paper away. You have to kind of break it down into steps so that they understand what you want, exactly what you want them to do. Because just doing the act alone as an abstract kind of concept they have trouble with. What about hemianopsia? Yes, they've lost half of their visual field, but it's very different from some other types of visual disturbances that you might be familiar with, because it's not like they've lost peripheral vision on both sides or central vision on both sides. What they will lose is, for example, the right side of their right eye visual field and the right side of their left visual field. So basically, they have lost peripheral vision on the right, central vision on the left, or vice versa. Very disorienting for a patient who may have some cognitive issues as well, some balance issues, and now everything that they look at is only, they can't compensate. You can compensate for lack of peripheral vision. If you know you can't see out here, you just turn your head. But if you know that, you can't see out here, but you also can't see centrally from your left eye, the convergence, everything is all out of whack. So hemianopsia. What is agnosia? You can't recognize objects or even use them the way they're supposed to be used. So oftentimes you would give a stroke patient a spoon and they would try to write something with it, because they didn't realize, they didn't make the connection that it was for their cereal. They thought you wanted them to write something. What is dysphagia with a G? Difficulty swallowing or chewing. How about alexia? Have trouble reading. Agraphia. Can't write. And what is neglect syndrome? Right, they neglect the affected side of the body, and it's not that they just don't want to use it, it's that they're not even aware that it's there. So if they are oftentimes, and that's usually with a right hemisphere stroke, left-sided weakness, oftentimes patients will not even know that they have a left arm or that there's a problem with their left arm. So they will not do any kind of care to the left side of their body. That's neglect syndrome. Not because they don't want to, not because they can't use it because it's paralyzed, they don't even know it's there. So there's some differences between what you're going to see in general with patients that have either left or right hemisphere strokes. So a left hemisphere stroke, so left side of the brain, which affects the right side of your body. So what kinds of things are you going to see with a left hemisphere stroke? What's that? Right-sided weakness, and that will go, depending on how long that patient has had the symptoms before getting treatment, could go just from numbness and tingling to complete paralysis of the right side of their body. Also, these are the patients that are going to have the aphasia, both receptive and expressive aphasia. So you'll have problems with speech, reading, language. So if you see that patient with right-sided weakness after a stroke, you can almost expect that they're going to have issues with speech and in language. Also, patients with left hemisphere strokes tend to be very slow and cautious and very depressed. So it's going to be hard to motivate this patient to get involved with physical therapy, to keep them motivated along any type of recovery track that you want to set for them. Now the right hemisphere strokes, so you have right-sided brain damage, left-sided weakness or complete paralysis and anything in between. These patients are more likely to have the receptive aphasia. So when you're talking to the patient with a right-sided stroke, oftentimes their speech is intact. And it just takes a little bit of conversation to figure out that their speech may be intact, but they are not getting what I'm telling them. And compounding that problem is the fact that most patients with right hemisphere strokes tend to be in denial about the fact that they've even had a stroke. And so they're very euphoric and everything is just fine and dandy and I don't have any problems. So you got a huge safety issue with this patient. Yes, Allison?
So with left-sided, they may not have expressive aphasia?
Right hemisphere stroke, left-sided weakness.
Right, but I thought you said they definitely have receptive aphasia.
Yeah, they oftentimes you'll see receptive aphasia in those patients with right hemisphere strokes, left-sided weakness. But sometimes they do not have the expressive aphasia. So it tends to be when you're talking to them that they seem to be understanding you, and unless you're aware that they have that receptive aphasia, you can't really verify that they're getting what you're telling them. And because of the fact that they're in denial and they're very euphoric and they don't think anything is wrong, oftentimes, the classic case is you go in to see the patient right before bed and you say, here, Mrs. Jones, here's your call bell. Make sure you ring it if you need to get up. And, oh, yeah, okay, no problem, honey, I'll do that. And then 2 o'clock in the morning, you hear a thud and a crash, and you go in, and Mrs. Jones got up to go to the bathroom by herself because she totally forgot and didn't really absorb the fact that you told her to ring and she's incapable of getting up and walking on her own. So safety is going to be a huge issue with that right hemisphere left-sided weakness stroke. Now it's not hard and fast, but it's kind of a generalization as to how these patients react to where the brain damage is from the stroke. So when the patient gets to the emergency room, even though we suspect that Mrs. G has an ischemic or thrombotic stroke, you're going to do a CAT scan. Because if she has a thrombotic stroke and it's been within usually about 6 to 8 hours after the onset of the symptoms, you can start thrombolytics. But you don't want to start the thrombolytics if she's having a hemorrhagic stroke. So the CAT scan is going to be probably one of the first things that gets done to determine what type of stroke she had. And so with the acute ischemic stroke, you're going to start with thrombolytics. And you can do it either intravenously or you may have a catheter directly into the artery where the clot is located to break down the clot. Once that has been done, or if we don't know how long the patient had the onset of symptoms, then you're going to start them on a heparin drip. And then other anticoagulants, Lovenox, Coumadin, Plavix, when they go home to prevent the formation of other clots. Why do you think we would give anti-epileptic drugs to a patient with stroke? Right, if they have ischemia to brain cells, some of those brain cells may start firing erratically and cause seizures. Intracranial pressure can increase, causing seizures. So very frequently they will be placed on anti-epileptics as a prophylaxis, as a prevention. So let's do some math. We have heparin drip. Mrs. G is going to have heparin 1875 units per hour. We have 25,000 units in 500 mLs of D5W. So what are we going to set the pump at? Because we don't have a smart pump, we don't have an Alaris pump where we can just program the units and it automatically calculates. We got to do the math. So what's our desired? 1875. What do we have? 25,000, and what's our volume? 500. So 1875 divided by 25,000 times 500 equals 37.5. So hopefully your facility will have a smart pump or other type of pump where you can just, it's already programmed with the formulary for that hospital, and all you got to do is plug in your units. But when you're doing heparin drip calculations, if you're on a heparin drip protocol, the math should always be verified by another nurse. And the protocol at at Johnson is that 2 nurses go to the bedside and reprogram the pump if you have to change the drip. So there's no mistakes either in the math or in the programming of the pump. Other facilities may not have that as a policy, but I think it's a good policy to have. Because a student and I walked into a patient one morning and found that somebody had programmed the pump for, I think it was, the order was 2125 and they programmed in 2215. They switched the two, so he's getting like almost 100 units of heparin extra for about 4 hours. And even though he was supposed to be discharged that day, the PTT that morning was over 100. So he was not happy, the doctor was not happy, and I was just glad that the student found the mistake and didn't make the mistake along with myself. So 37.5. Now because of the PTT, the doctor says we need to increase the heparin by 1,200 units per hour. So what is our new desired? We had 1875, and now we have to increase it by 1,200. So what is that? 3,075. So 3,075 divided by our have, which is 25,000, times our volume, which is 500. And what do we get? 61.5. This is a very common calculation that you will find on NCLEX, and you will also have to do in real life and in practice. So our ongoing assessments, regardless of whether the patient has had a thrombotic or an embolic or hemorrhagic stroke, the first 72 hours are critical because that's when the intracranial pressure can start increasing. So what are some of the signs that we talked about last week of increased intracranial pressure? Decreased level of consciousness, hypertension, bradycardia, so Cushing's triad, widening pulse pressure. What's papilledema? That's when it's swelling, hyperemia of the optic disc. You may also hear it referred to as choked disc. Very common sign of increased intracranial pressure. So your baseline neurological assessment is going to be very, very important for these patients. You need to know, do they have a hand grasp? And now all of a sudden over that 72-hour period they don't have hand grasps anymore, or it's weaker, or the pupils are sluggish, or there's a change in the speech or the behavior. For surgical interventions for patients that have had a stroke, if they have an embolic stroke, they can have a balloon angioplasty, just like the coronary angioplasty. They can have an endarterectomy, which is what? They clear out the plaque. Well, they can actually, an endarterectomy is removal of a clot from anywhere. So they can, a lot of patients you'll see that have had TIAs, for example, will have carotid endarterectomies because they have occlusion and plaque in their carotid arteries, and that's what's causing their neurological issues. They can even do bypass. Just like you do coronary artery bypass, you can do a bypass of cranial arteries. For hemorrhagic strokes, patients will have radiologic occlusion, so radio waves zapping and trying to stop the bleeding for smaller bleeds, or they may have to have a craniotomy and go in and actually clip and sew up and repair the ruptured blood vessel. In general, but it's not, again, a hard and fast rule, patients with embolic strokes, the symptoms tend to come on very slowly and gradually. Whereas hemorrhagic, if it's particularly if it's a large bleed, they will be neurologically impaired very quickly. And oftentimes a very high mortality with hemorrhagic strokes, because oftentimes patients don't, by the time they fall and somebody calls the doctor and they get them into the emergency room, they've already bled out. Yes?
Can it grow new arteries?
Not really. Not really. So they do have to bypass, use, just like they do for a coronary artery. Like sort of collateral circulation, like patients can develop. I would.
Just because, the only reason why I ask is my boyfriend's sister has moya, which is like the narrowing of the arteries
Mm-hmm.
in her brain, and she had a stroke a couple months ago, and she had surgery on her left side, and she had bypass. And so when they were doing all the workup and everything, they actually saw new
Circulation. And I think probably in younger patients that will happen. They'll start developing more collateral circulation, but probably isn't going to be mature enough to deal with a lot of, if patients are continually throwing clots and have other issues. So she did have the bypass. How long did that surgery last?
Actually, that side is fine. She's going tomorrow to have the other side done because that's the side she had the stroke on.
Yeah.
So they're not going to bypass that side.
Wow. And how old is she?
31.
Very young to have to go through that. So now we're getting into the post-hospital care. Mrs. G's family doesn't want her to go to short-term rehab. So what is going to be your discharge teaching for this patient, given the type of stroke that she had and what you anticipate she might go home with? Coumadin. So Coumadin teaching. She's going to be on Coumadin probably for the rest of her life because she has this valve issue that has probably caused her stroke. What else? What kind of services do you think she'll need? Right, physical therapy, occupational therapy, and speech therapy. She has slurred speech, she has one-sided weakness, she's going to need a lot of work with performing her ADLs. She's going to need blood levels checked. What do we have to check for Coumadin? The INR. And what's our target? 2.0 to 3.0. So either the visiting nurse can pull that, or PTI, the PT-INR finger stick machine, which I love that, is a wonderful invention, or the patient may have to go to the lab. So all of this is going to be part of your post-care for that patient with a stroke. And Mrs. G was my mother. So we were that family. No, I wasn't even a nurse then when she had the stroke. She was so young. But yes, she had a mitral valve, mitral stenosis because of rheumatic heart disease. If I had been a nurse or a nursing student, she would have been a textbook for listening to heart sounds because they were the most unusual and interesting heart sounds. So after I went through nursing school, I used to do a lot of identification of heart sounds with her. But of course, after the stroke, she couldn't have a valve replacement. Prior to the stroke, she could have, but the cardiac surgeon said, no, you're young, it's still relatively experimental, well, let's wait a few months. And within a few months, she stroked. So patients need a lot of teaching. Families, if I had been a nursing student or a nurse and had known the warning signs, and when she had the TIA 2 or 3 months before, I probably would have really pushed and really advocated for her. But you know, she goes to a doctor and you tell a 59-year-old woman you don't need open heart surgery. Is she going to beg for it and plead for it and, you know, force the doctor to do it? So that was, but she did live for about 25 years after that.
Did she have a lot of deficits?
She had, she was not able to work anymore. She was not able